Up to you.
Thank you very much. How are you guys? I hope you're all okay and you're quiet in this very cold days. I'm gonna just describe to you how to deal with an amputation case in your short cases. It's a very easy session to get the full marks in it. Before we decide on everything, you need, when you speak to one of these patients, when you see them coming to you, you need to understand the following things. If you see the patient, comment whether it is a transtibial. Most of the problem will come as lower limbs. Very, very rare you will have an upper limb. So either you have a transtibial, transfemoral, through knee, signs, or partial foot. You have to comment on the level, incision, and what is the length of the stump, what is the stump problem you can see, like wounds, swelling, ulceration, pressure points, and you don't forget the sound limb. To start with, I'll go through them quickly, and please feel free to stop me if you want some, if you want some explanations. Transtibial amputation. You have two types of prosthesis you can see, and we'll see them all in pictures now. First of all, you comment on the stump. Second thing, you comment on the type of socket and prosthesis you're going to see. Just to summarize, we call it PTB or total contact socket. You have an interface, which is something between the skin and the hard material of the socket, and how to keep the limb attached to the body. And then you talk about a socket comfort score, and then you see the patient walking with or without, and you comment on the gait deviation. Transfemoral is the same, but you need to add what is the type of the knee and what's the type of the foot. Again, at the end, you comment on the gait. Either it is antalgic. I presume that you know this terminologies. Antalgic, spinal deviation, shortening, or length, or pistoning. Please stop me if you don't know anything so I can proceed on. Is that okay? Now, what is the first thing we see? To comment on a stump. What do you have here? Can we make it interactive a little bit, Mr. Mohammed?
Yeah, we can. So guys, if just raise your hand if you want to ask for any question, and then you can unmute. If you raise your hand, I can unmute you in order, so you can ask your question.
Or even answer, يعني عشان make it a little bit interactive.
No, yeah, no problem at all.
What is this type of amputation? What level?
Transtibial.
Hey, transtibial. So what is this type of incision now?
Yeah, transtibial with posterior flap.
It's long posterior flap. Is that okay? Because there is skew posterior flap as well. So it's long posterior flap. How would we know this?
From the shape of the stump.
Absolutely.
The incision usually in the front, while the one is fish mouth. The other one
is
fish mouth.
Or what you call it again? Equal anterior posterior flap. Is that okay?
Yeah.
What's wrong with this incision?
It lies on the weight-bearing surface, just essentially at the level of the bone stump. So it may ulcerate, it may have pressure sore, it may not heal appropriately.
دكتور أحمد كده مش كده؟ أدهم. أدهم. Don't أنت بتوصف بس. You are only describing a case. واخد بالك? Don't jump into conclusion. So what you have here is an incision which is puckered in the middle. It shouldn't be like that.
Okay.
So this is done under tension. Yeah. And this will lead to gaping as well here, as you see. And what will happen is that an ugly, painful scar. It shouldn't be like that.
Yeah.
طيب what is that بقى؟ What you call this incision?
Anterior posterior flap. Long anterior posterior flap.
Is this the Q flap? Or...
It is the same like the equal anterior and posterior flap, but skewed. Skewed يعني معوجة. Do you know the surgical techniques, or do you want me to go through it? Because they will ask you about it. Okay.
You can go through it, please.
يعني, see, if you need to do that, you need to measure the optimum length of, what is the optimum length of your cut?
12 centimeters distal to the tibial tuberosity, I think.
معلش قلتها دكتور عمرو.
12 centimeter distal to the...
Why not 15?
12 to 15. So
Why
again,
not
it
16?
depends. It depends on the patient's height and yeah, it depends on patient's height. So there are different rules in measuring how long the stump should be.
يعني, just give me an example. What is, if I ask you in the exam, what's the optimum length? What you gonna tell me?
1/3 of the leg length.
Why not more than that?
The longer, the better.
حلو. طيب, I'll make it easier for you. You measure it like for every meter, you take 8 centimeter. Okay? يعني if the patient is 170, so the length you should do is about 15 centimeters.
15.
Okay? For every meter of height, you take 8 centimeter. 8 centimeter from where? From the medial tibial plateau.
Yes.
Okay?
Yeah.
We'll talk about it so there is a rule for it, but it depends as well on the other limb. Yeah, you need to check the whole lot. You're not amputating a limb, you are looking at the whole patient. Okay? طيب. So we talked now about the different incision. You have seen them. Okay? So this is how it looks like. A skewed flap is like equal anterior and posterior flap, but it is skewed a little bit. And I did another presentation about the surgical technique. We can go through it, and I actually teach this to the vascular surgeon. Now, what is the problem we see here, Ba?
Dog ear.
That's very good observation. But what else? Why did you have a dog ear?
Because the length of the flap posterior is more than the double of
How to measure the long posterior flap, Dr. Ahmed? And I'm sorry, I'm not examining you. I'm just giving you, just to make it all.
هو ال section of the bone level of osteotomy should be at the angle of the between the flaps, and the length of the posterior flap should be the double of the anterior flap. I'm not sure if that correct or not.
بص هقول لك easier to do it this way. Can you see the cursor here? Yeah.
أيوه.
So here you measure the cut end of the bone.
Yeah.
We're talking about 15 centimeter from the tibial plateau. Okay. Now we measure the circumference of this area. يعني لو لقيت circumference around this area, say 30. Okay. Add 5 centimeter to it for the whole length. If you measure 35 from the medial tibial plateau, 35 here.
Yes, circumference ونقول double circumference صح كده؟
مش double, لا تزود 5 سنتيمتر بس.
5.
double ده هيبقى يعني لو صرت هتجيب 60 منين؟ ف5 من الميديال plateau down there. And then you reflect it anteriorly, but what sort of muscle do you have here?
Gastro.
صح. And what is deeper to the gastro? Soleus. Excellent. So gastric and soleus. So for us to have a uniform stump shape, cylindrical, you need to shave a little bit of soleus. Or to refashion it to close this circumference. So what happened here is a surgeon who left a big chunk of muscle here and did not refashion it. And also, he didn't measure, he did not do the lengthwise try, because see how short is it?
Yes, it's very short.
فهو سايب حتة كبيرة, big chunk of muscle راح قافل. For once it closed, it left this big problem. Imagine you put this in a socket. I'll show you the socket in a minute. This will go ischemic straight away, especially in diabetic, yeah? Now, let's see about this one. This is a lady from Tanta, by the way. And we did a course, and we had prosthetists with us from England. And I asked her to take that picture for information and teaching consent. Yeah. So she's lying on her tummy. And what do you see here?
This is the pressure source.
Yeah, exactly. From a socket, you can see the socket here.
Socket, yeah.
But why is it happening?
She's
Overfitting.
valgus knee.
She's lying on her tummy. How can you comment on valgus knee here?
In her tummy. Oh, this is the back. Sorry. Okay.
So the stump is quite bulky distally, so that leads to pressure proximally, I believe, when it's sat, and cause the pressure sore.
So imagine this is a long posterior flap. It is bulky, as you said. It is longer than it should be. It was not refashioned, so left a big redundant tissue. This is not controlled in the socket, so she has excessive movement between the socket and the skin. Has this all the time. ماشي? طيب. This tell you, just before you do any amputation, you need to well plan it. Okay? Now, what about this? This is my patient in my clinic here. What is he pointing at?
Is it the bony prominence?
Why is it happening, Dr. Ahmed?
هو ما عملش المفروض connect the flap with the periosteum anterior to make like a good soft tissue coverage over the bone.
No, what he did exactly what you said, Dr. Ahmed. The idea is to do osteomyoplasty. That's mean when you come to the cut, you drill few bones. Sorry? You drill two holes in the anteromedial antero aspect of the patella, of the tibial cut, and then bring the soft tissue around it and tie it through an ethibond or long-lasting.
يعني هو يخيط في البريوستيوم؟
لا، هو يخيط في العظم.
العظم نفسه. Okay.
ليه البريوستيوم بيفيل. This is more failure of myoplasty, and this is extremely painful. العيان ده مش عاوز يمشي لحد دلوقتي. Because of this, and it was sent for a revision. Okay. طيب, what is that now? What do you think about this?
Very short stump, very short bony level. So the amputation was there.
Believe it or not, this is from the textbook, because the textbook will tell you the shortest we can get is to allow some flexion of the knee. Okay? But this is completely wrong. Why? Because what is it between the tibia and the fibula?
Syndesmosis.
Interosseous membrane. So interosseous is not up to the full length between the tibia and fibula.
Yeah.
Is that correct?
You
know?
Yeah.
But if you're gonna cut this to that length, you have to cut the fibula shorter. So the principle of cutting the fibula and tibia is just to cut the tibia around 15-16 centimeter and bevel it anterior and use a rasp to bevel it and round it. And then cut the fibula 1 inch above here, 2.5 centimeter above this cut. So imagine you cut here, so it will be above the syndesmosis or interosseous membrane. So what attached to the fibula here?
The lateral collateral ligament.
Excellent. Lateral collateral ligament. And what else?
The biceps tendon.
Exactly. So what will happen? This, we call it a floating fibula. So with every swing phase, the biceps will bring it out. and it will protrude through the skin, and it can cause ulceration in a diabetic. I have a patient who died from sepsis because of that. Because she kept on having problems after problems, diabetic, not well controlled from the fibula, and we couldn't control it. How to get rid of this? واحد يقول لي إن إحنا remove the head of the fibula. Exactly. But it's a big take because you need to reconstruct the biceps tendon and the lateral collateral ligament, or else the joint will open laterally. It will be knee instability. Yeah? Is that clear?
How can we do that? Should we reroute the in the muscles or in the tibia?
In the bone.
The bone.
The tibia. But ideally, you should go through knee. It will be easier because this is a non-functional part. Why is that? I'm going to explain it now. If you examine a socket, yeah? If you examine a socket here, you'll see a socket. ايه هو البروسيسز? A socket, shin tube, ankle and foot. Okay, it come into different type. So for us, it's a socket. How to move inside the socket? We have two types of sockets زي ما أنا قلت لك في الأول. PTB and total contact. PTB means you put the pressure around the PTB area, patellar tendon bar area. And then the total contact means the pressure will be distributed all over the stump. How would we know both? I'll show it to you in a minute. طيب ايه الidea هنا in when we move we're getting here early here strike, sorry, early heel up. The PTB area will get the pressure, and because of the socket movement you have the pressure socket forces posteriorly. Okay, so this is what creates the pressure around this area. طب نعمل ايه؟ Sorry. This is how we differentiate between the two. Socket here is PTB. See, when you امسك السوكت في ايدك تبص تلاقي ريدج هنا. See that? In the front, and a counterpart in the back. And that to load the PTB area and the hamstring area. When you look at it from the side, front there is a ridge and a counter ridge in here. So the pressure will be distributed in this way. A pressure sensitive area and a pressure tolerant area. The pressure tolerant area is the PTB, sides of the tibia and the posterior aspect. عشان كده لما نروح back هتلاقي ال PTB area هي اللي بتاخد ال pressure وال posterior aspect of the stump. Okay? طيب. How would we know the difference? This is the difference. PTB في ridge on top, on the back. طيب. Ridge و suspension بelastic suspension. So you commented already on the stump, you commented on the type of the socket, and you commented as well on the suspension, which is an elastic rubbery socks or sleeve goes above the knee. What's the difference between this and a total surface bearing or total contact socket? Total contact, there is very smooth, very rounded. You see? There is no pressure areas here. Patellar tendon, yeah, can see that? And the back here is completely smooth. So the pressure will be evenly distributed all over the stump. How can we suspend it then? We suspend it through an interface, which is a liner, with or without a pin. Okay? It goes into here, and it attaches itself to a mechanism here. You don't need to say it in details. But now let's go back. So we have two types of socket. PTB, pressure areas بتاعته اهي. How to hold it to the skin. The other type, total contact. What's the interface? Is a liner, goes onto the skin, and then go into a ratchet here. This liner, it will be with a pin or suction without pin. Is it clear or not really?
Yeah, clear.
No, clear, thank you.
Yeah. Now we have to comment on the type of foot we have. look at the foot itself. If you see a block like that, we call it sash foot. انتوا عارفين الساش foot. Sash equal to what? Solid ankle, cushioned. So the movement, there is no movement in the foot and ankle. Just a block of wood. Why is that? This is a carbon fiber energy returning foot, or you call it mobile foot. Okay? This is a blade, easy. And this is a new one, but you'll not see it in the exam because these are more private patients, so they don't go to exams. This is a microprocessor, a computerized ankle. Okay? So either you will see one of the basic non-mobile or a mobile foot. And it comes into different shapes. Both. You look inside, you see the carbon fiber. Okay? So now you describe what you call it, the lower end. So now you have a transtibial amputation with you. You commented on the stump, on the lens, on the incision, on the problem you have seen, on the type of socket, type of foot, and then you ask the patient to walk and describe what sort of gait does he have. Simple as that. And now you have the marks all in your pocket. Okay, now let's talk about the transfemoral. Are you okay? Yeah, anyone for any questions?
السؤال بس يا دكتور أشرف، لما بيجي مريض في الفايفا like photo in the Viva or patient himself with some sort of prosthesis and we have to comment?
He will come to you as a patient. Either he will be lying in bed or coming to you walking with a type of prosthesis.
Okay.
هو دلوقتي دكتور أشرف، هو دلوقتي so Viva you'll have the prosthesis on the table. So clinical may be the patient, but for Viva, either you have a photo on the computer or he have some orthotics and prosthesis in front of him and start asking you to describe.
Can be an intermediate or any short case examination.
No, if you have a case in intermediate with amputation, you have to comment on the prosthesis. So it will not be a prosthesis station. It will be an intermediate station, but you have to comment on the prosthesis in the commentary. But Viva, he will be either having photos on the computer, on laptop, or iPad, or he will be some of them, they put in front of them orthotics and prosthesis and ask you to comment in each one.
Okay.
Exactly. نيجي للtransfemoral. Transfemoral, you know exactly the biomechanics, you know the mechanical axis and anatomical axis. Yeah, what's the difference between the two?
6 degrees.
So what makes a 6 degrees? ربنا خلقها كده. What is the forces acting in here?
The tensile force on the medial aspect of the femur, a compressive force on the medial aspect of the femur and tensile force on the lateral aspect.
Which group of muscles?
The adductors.
Sorry?
The adductor magnus, longus, and brevis. They do adduction.
And what about the abductor?
The abductors, mainly abductor medius and minimus on the greater trochanter.
Yeah, which is?
And the iliopsoas.
Gluteus medius and minimus.
Yes.
Bravo عليكم. So this is the idea how to keep it in place. When we amputate, the aim is just to keep this biomechanics intact. And why is that? You'll know that in a minute. So when we do the surgery, we measure between 16 to 20 centimeters the apex, yeah, from the contralateral medial tibial plateau. This is the length of the bone. This is fish mouth, you call it, or equal anterior posterior flap. But what you need to do here is just to skive. What is that?
16 to 20 centimeter.
16 to 20 from the opposite or contralateral medial tibial plateau. You get it or?
Yeah.
Yeah. So what is this? This is the adductor tubercle. So when you came to, you opened, you dissected, you ligated your vessel, you identified your nerve, and now you come to the muscle here. You have to skive it from the adductor tubercle because it's a big fleshy muscle, as you see here, adductor magnus. Why? Because the power of the adductor magnus in doing the adduction is 78 more, which is the strongest one of them. Okay? So what will happen here? You cut it, we leave it long. And then you ask your assistant to push the femur medially and do 2 holes in here and reflex the adductor magnus onto the lateral aspect, and you tie it with Etibond as well. They said as well, this is American Society Orthopedic. When we do the quadriceps as well to tie it to the hamstring posteriorly. I have to say that this specific step has to be like judged by the vascular orthopedic surgeon, because if this is ischemic, it's going to be very bulky and can dehease quite easily. So you have to be careful on what you do. Okay. So, and when you look at the X-ray, you look at the X-ray. If you have an X-ray Viva, you can see here it's kept the balance here. What you call it, muscle balancing. So you got the adductor attached to here, but in this situation, this patient did not have this muscle balancing. So what will happen is unopposed forces coming from the adductor to the abductor, and though with every stance, and why is it in stance? This patient has his X-ray in standing. So why is it pushing laterally?
Abductor will be in action because of the joint traction force on the hip.
Absolutely. A hip and the pelvis, because this is the main muscle to cause a Trendelberg. Yeah, we do the Trendelberg test. So it will be in action here all the time. So when it moves the femur laterally and it hits the socket all the time, quite painful, with or without using a prosthesis. Yeah. Okay. Or it creates bursas, infection, weakening of the bone, inflammations. Sometimes we see here like open wound with osteomyelitis, has to revise it simply because you didn't do this. Okay. Now, as for the socket now, we have 2 types of socket. Ischial containing socket and ischial bearing socket. What is ischial and ischial containing? Simply, ischial bearing, when your ischial prosthesis, ischial bone, land, you sit on it. يعني هنا ischial quadrilateral socket here. You see there is a shelf. Can you see it? And the ischial bones sit on it. In ischial containing is more proximal. It contains the rami and it contains a greater trochanter, so it will be more intimate to the patient. In here, there will be a movement up and down of the femur, and then it goes up, and then the patient rests on the come and down and rest on this move. So what is the difference? To be honest, currently, we all use the ischial containing. This is more anatomical, more biomechanically friendly. But we use this for old patient or patient with a soft tissue, big soft tissue, where we cannot control the soft tissue within a socket. For what will happen here is the patient who cannot tolerate this intimate groin part will leave a space and it will move up and down. Okay. Yes, it can give him some pressure relief, but it can cause pain as well around the ischial tuberosity. Is that clear or not really?
So the ischial is most commonly used now, ischial containing.
Ischial containing. So what you have when you see a case of them, you look at the socket. عندك socket at table. If you see it high like that, it's ischial containing. Okay. If you see it quadrilateral like that with a shelf in here, This is ischial bearing prosthesis. Okay? Easy?
Easy.
Make sense or not really?
Makes sense.
Ischial containing had ischial bearing area but embedded inside. You'll see a small thing, not as prominent as this shelf here. Okay? If you have it on the table, you have two types of socket, ischial containing or ischial bearing. Ischial bearing, it will be like square type of this. Ischial containing, long, cylindrical, with a high lateral border enclosing the greater trochanter. Okay? Now, what do you think this is?
Ischial containing.
Ischial bearing.
Containing. This is high,
Oh,
intimate, going to the groin. Yeah? The same here. Okay? Ischial containing, it looks like a square. Okay? طيب. What's attached to the socket here? Now you have to comment on two things. Knee component. Is this knee fixed or mobile? Simple as that. If you see a cable like that, it's a fixed knee. If you don't see this cable, so it's a free knee. Free knee means it swings with you in the swing phase. Fixed knee, it remained fixed. So it moves as one entity. This cable is to keep the knee fixed in one position, but when you sit down, you pull this cable, the knee will bend in sitting position.
so
Okay?
the only movement in the fixed knee is just a 90-degree flexion.
في الأنهي
في الفيكسد.
Fixed only in sitting position. ما انت الواحد ما بيقعدش, you don't sit with your knee extended in front of you. So on the socket, you'll find a cable attached to a kind of screw. When you pull it, it will bend the knee and the patient can sit down in bent position. Apart from this, when you stand, the knee will flick and become very stiff. Make sense or not really?
Makes sense.
يعني انت لازم, يعني you have to see it, but at least I tried to get a picture of it. This
واضح
type,
المبدأ واضح.
sorry يا محمد.
كنت بحكي انه لا واضحه الفكره واضحه.
If simply as that, شفت كابل محطوط في السوكت means it's a fixed knee. Simple as that. There is no cable, so it's a free knee. What type of free knee is not your problem, to be honest. It will be very cruel from the examiner to examine you what's a type of free knee. We don't ask this question for the rehabilitation registrar. So complicated, okay? So either fixed or free, okay? So what's the difference between fixed and free? Fixed, move in the swing phase as a one entity, doesn't bend with you. Free, bend with you when you do the swing phase. And this is, by the way, if you see this shape, this is a microprocessor knee, computerized knee. What type is not your level now. Now, how, yeah, تفضل.
وفي انواع اللي هي السنجل اكسس والحاجات دي اللي هي الفريني.
بص, single axis, weight bearing activated, 4-bar knees, geometrical, all free.
كل ده فري.
بس في single axis fixed. لما تلاقي cable attached to the bone here, to the socket. Okay?
تمام.
Yeah? شفت cable, it's a fixed knee. Okay? Now, how to attach it to you? Either you attach it with a rigid belt. How would you know a rigid belt? A hinge outside. Or a soft belt. طب what is the interface? Either you see a cotton socks, يعني العيان بيلبس cotton socks, or a liner with or without a pin. All what you need to say, liner as an interface, or socks as an interface, soft belt or hard belt. So you commented on the
السسبنشن دكتور اشرف بيتكون من اللاينر والبيلت.
في ناس بتلبس لاينر بس عشان عندهم جود كوادز سوري جود جلوتس، فما بنحط لهمش بيلت.
تمام.
ليه بقى؟ This is a suction one. The patient wears this and because of the suction هقول لك اهو. You'll see here a valve. So he goes into that, expel air out, valve will close and it will be completely attached to him. Okay? So he wouldn't need an auxiliary belt. So you have ischial containing, ischial bearing, interface, either a liner or a sock, a suspension, whether it is a free suspension, yani without belt, or a hard belt or a soft belt. Why do we use a hard belt? If they ask you this question. Give it يعني a thought about.
لو ما فيش سكشن في الانترفيس.
لا ليه بنحط هارد بيلت؟
لو
sit on the iliac bone.
No.
Rigid.
This is the lateral aspect. This is greater trochanter is here.
لو المشكلة مشكلة بيستونين.
مشكلة ايه سوري؟
بيستونين.
لا مش بيستونين لا.
ممكن نيوروماسكولار يعني ما فيش دكتور فورس.
If you don't have enough gluteus medius power in here, that means that this will act as an extra hip joint. If the patient can will Trendelberg without a belt, that means that he will fall all the time he moves or swing his leg. If he has to supplement it with an extra force here around the gluteus medius area. Okay? For people with weak gluteus medius, we prefer to give them a rigid belt or a soft belt if they have a reasonable 3/5 Oxford scale. But people who can control their movement within the socket, we can use one of them. Is that okay?
تمام.
Type a new single osseointegration. What is that? Have you seen one? Because in Leicester, they asked me because one patient came in with this prosthesis. So it's a direct skeletal fixation. Means stump, especially short stumps, what will happen? Put a screw, medullary, fixture, and then abutment, wait for the skin to heal and attach the prosthesis directly to the abutment. Okay? So what will happen? What is the main drawbacks in this? You know it very well. I'm sure you're going to tell me.
Infection.
Absolutely. Infection or
loosening. Or
and what will happen? If you have infection or loosening, even if you have pus coming out of here, he won't be able to wear even a traditional conventional socket. And then he will be a wheelchair bound for a period of time anyway till the clear. And what the hell we have here, what we call it a fail-safe device. And this is a problem in UK. A fail-safe device is that when a patient have a fall or this disruption of mechanism, instead of falling and breaking this bone, there will be a fail-safe device. It will crack before. fail-safe device دي عليها مشاكل كتير.
What is the name? Fail-safe drive?
Fail-safe, F-A-L, device, fail-safe. That breaks before the screw breaks. Okay? طيب أنا عاوز يعني quickly, are we okay with time, Mr. Muhammad?
Yeah, we're fine.
No.
Yeah, go ahead.
Now we have a different type of prosthesis, we call it here. So what is that? What's the difference between, take this reference with you everywhere. If you could take a picture of it on your phone. Is the transfemoral better or through knee better option for you?
Transfemoral.
femoral.
برافو عليكم. ليه بقى؟ طبعا this is the wrong answer.
The longer the better.
More energy conserving.
Yeah, the
اللي
longer
هو
the
ايه؟
better.
اللي هو لا خلونا نتكلم scientifically شوية. Which is better?
The longer the better. The longer the stump, the better
Are you sure?
بس
So
هو
transfemoral.
exceptions.
هي بيتر في الانرجي كونسامشن ماشي، بس انت عندك مشكله كبيره في فتن الارثوزس
البروستاتيك
هو
ليه؟
البروستاتيك سوري.
ليه؟
الترانسفيمورال هتبقى عندك مشكله في انك تفت البروستيسيس.
ليه؟
ليه؟
Through knee is more practical for pediatric patients as per data,
والله
while for adult.
أنا كنت عاوز أسمع الكلام ده.
بس
while
دي
for
قصه تانية، ده عشان خاطر they still growing، يعني مش هي دي المشكله.
طب بص، الكلام ده لو قلته في الامتحان هتسقط اللجنة دي.
بس through knee هيبقى فيه unequal level of the knee because we have to fit the prosthesis with the knee.
الله عليك، الله عليك. مين دكتور؟
أحمد الخشب.
أحمد، الله عليك. هتكسب ال sorry يا Mr. Muhammad, and I'm talking in Arabic, but
So
is needed. It is actually, what you're saying is right, but there is no absolute right or wrong in both cases. Yeah? What we'll have here is actually a through knee has its advantage and a transfemoral has its advantage. One has its own indication, one is a contraindication. Actually, the through knee is a very common now, not always in pediatrics. This is the old books will tell you that. Now, most of the veterans, they go through a through knee. Okay? So what is the advantage? We'll talk about the advantage and disadvantage. But look at this. This is since 1990. See? This paper. And what do you see here? This is a transfemoral. What do you see here? This is lateral, this is medial.
The bone started to penetrate the skin.
ليه?
Because there is
muscle
no
imbalance.
Absolutely. See how good it is? Yeah? So you have a soft tissue dangling here, and it is a pressure against the skin. Not penetrating as yet, but it's going to. Now, this pros and cons of each. Okay? Now, what is the downside of it? Here, it has so many surgical approaches. One of them is a long posterior approach. You leave a sleeve from the gastrocs, we reflected anteriorly. But here, the surgeon decided to see a very long sleeve with an attached patella. Attached to what? The patella is attached to what when you do through knee?
The patellar tendon and the quadriceps.
لا ما انت خلاص you went, you disarticulated the knee. You left the patella with a patellar tendon. So you attached the patellar tendon to what?
The lower end of the femur.
Where? What is the structure you have in the femur left? Posterior cruciate. Remnant. So you keep stump of the cruciate ligament and you attach it to it. This is if you decide to keep the patella. I have a long presentation on whether to keep or to remove the patella. So here he decided to leave a long sleeve, so it acted like a transtibial, a short transtibial, which added to the length of the prosthesis. Okay, and what is this type of through knee? It's well known in your orthopedic books.
Great.
If someone, سوري
Great
انت قلت الكلام ده مظبوط. Great Stoke.
Great Stoke.
Great Stokes, what's the principle here? He said one of the downside of the Siruni is that the condyle will be prominent. So then it will be an ugly socket because the socket has to go around the condyle, prominent condyle. So Great Stoke decided to remove the condyle as if it's a long transfemoral, keep the patella denuded from the cartilage and attached to the end of the femur, يعني reflected or attached to the end of the femur through Etibond or something. I personally, and all my rehabilitation colleagues, I hate this type of surgery. By the way, this is a patient of mine, and the surgeon is a friend. He rang me. I was in the clinic. He said, Ash, I couldn't find a good muscle cover. I need to go a little bit up to remove the condyle. I still insist on doing Siruni. I told him, why don't you do a transfemoral, normal, and leave it? He said, well, there is a good quality of bone. I'll take this out, blah, blah, blah. Fair enough. Am I trained? Are you trained to do this? Yes, I am. I've done it before so many times. This is day 2 post-surgery. It failed. So you have a sharp bone of end here and a sharp bone of end. What is a good thing about the Siruni is an end bearing, not an ischial bearing. Do you remember? Yeah. What do you mean by end bearing? Can you see me? Because I cannot see myself.
Yeah.
End bearing means this is a socket and this is the end of the bone. It will move with you. You put pressure in the lower end of the socket. So it will be part of you. And then the socket doesn't need to go up to the ischium. It needs to go to the 2/3 of the femur. So then he can sit properly without causing any pressure on the ischial area. Now, if you go through this and end bearing on these sharp ends, it will be a nightmare. And this patient was diabetic.
هو الايديال ايه يا دكتور اشرف؟ عشان انا مش فاهم، هل هو المفروض يسنترلايز الباتيلا؟
لا، يشيل لو في المنظومه دي ما يعملش الموضوع. Great Stoke we don't like it because we are define the objective of end bearing. هنا خلاص مش ما ينفعش تبقى end bearing، صح؟ idea either you leave the condyle, remove the patella or keep the patella attached, or go through a transfemoral. Don't do this. حضرتك ازاي؟ لان انت كده defying الاوبجيكتيف ان هي end bearing. خلاص لازم نوفلود this area. It's a painful area all the time. So you have to offload it now. So you have to get the socket up here. فانت بص بقى حضرتك السروني. Who said it is you need to fit a knee? دكتور عبد العزيز؟
انا قلت ان هو احنا هنحتاج نفت ني، فيبقى الني
الله عليك، الله. دكتور احمد خشب، الكلام ده صح جدا. Very important. ايه اللي حاصل هنا؟ لان التو knee equal in sitting position. We have to fit a knee. فلما sit down here you can see a discrepancy, lens discrepancy. And this is awful when you sit down in a bus or in a car or in a cinema or any tight place. But actually it more energy conservative. So who said that it is more energy, less energy consumption? Who said that?
the longer the better in
مين اللي قال؟ حد فيكم قال؟
انا وادهم.
انتوا اتنين شطار. فهي very very self-suspending. ليه self-suspending؟ لأن السسبنشن goes around the condyle. واخد بالك ازاي؟ فمش محتاجة تروح لحد الهيب فوق، فكفاية لحد هنا. and end bearing يبقى كأنها a big sock. Is that okay? This is different than the ischial containing here. You see that?
مش فاهم دي.
اللي هي ايه؟
هو احنا ليه طولنا السوكت؟ طيب هو
مش طولنا السوكت. السوكت is molded to a long stump، مش كده؟ we didn't convert. بس احنا we have to add a knee.
دي
on top
يعني
of
دي
it.
علشان ثروني يا احمد، هي اوريدي اطول، لانه يعني لان هي مش ترانسفيمر، هي دي ثروني.
صح كده ادم. يعني بص، لو احمد، لو هي through above the knee, do you look at the cursor here? Can you see it?
ايوه
هتبقى هنا، فالني لما تتحط تبقى هنا، لكن
أيوة
بص
تمام.
through knee والني تحت اهي.
ايوه.
فلما يجي يقعد هيبقى في discrepancy, lens discrepancy. How do we manage that? We put what we call it a 4-bar knee, and when it bends underneath the socket. فتry to minimize the socket. طب بس دي free knee. What happen if we want a fixed knee؟ اهو كيبل اهو، شايفه؟ نفس ال4 بار بس fixed.
تمام.
شفت بقى؟ كيبل
لا،
means fixed. اوكي؟
اوكي تمام.
طيب تمام كده؟ يعني أنا مش عاوز أقول لك إن most of the people I went through the Viva, they didn't know these levels. Do you know these levels?
انا عارفها دي
ليس فرانك، شوبار، بويد، بيريغوف. لأن هنخش على الأورثوتيك بقى.
البيريجوف ده هو اللي مش مشهور قوي، بس غير كده عارفين
ولا
الباقي.
البويد ولا
لا
البويد.
لا البويد عندنا في الاورثوبيديك
الصايم.
مشهور قوي.
البويد والصايم احنا عارفينهم
البويد والسايم
يعني مستعدين للأسئلة؟
لا
مش
يعني مش
طب
قوي
ماشي.
كده.
لا، هو حضراتكم بتشتغلوا فين الأول؟
انا في نيوكاسل.
نيوكاسل و
انا في بريجنت في الساوث ويست.
يعني ما فيش شغل. ماشي.
اه
طيب ترانس ميتاتارسال، ليس فرانك، شوبار، ده بيتعمل الفاسكولار تملي يغلطوا اي حاجه هنا يقولوا عليها partial foot is not really. اوكي. طيب انا لما جيت امتحنت الفايفا ما حدش عارف ولا حاجه من دول، كله عارف الترانس ميتاتارسال. after that nothing was happened. Can you define a science for me؟ مين اللي بيعمل ساينس كتير؟
هو انكل.
طيب يلا describe it بقى.
الصايم احنا بنعمل ديس ارتكوليشن في الانكل جوينت، وبنليف الهيل باد علشان نعمل جود اند جود ستامب فور ويت بيرنج.
حلو.
ولازم
What's
الماست
the indication of science؟
اي كوز اوف جنرال كوز اوف امبيوتيشن انفكشن.
لا
some diabetic foot
مش
problems.
دي ألعب من اللي حضرتك قلتها دي. طيب diabetic foot, what's their main problem؟
الفاسكولاريتي we have to get intact posterior tibial artery for the
Allah. So this is one of the indication. If you don't have an intact posterior tibial, you don't do science. Okay. Neuropathy. Is neuropathy a contraindication؟
لوني على طول طبعا.
لا طبعا it's not. It's a relative. It's a relative.
مش ماشية معايا خالص النهارده.
معلش بقى، ما لازم
يومك النهارده يا ادم.
So it's a relevant contraindication. Why do we say it's what did you say it's an indication؟ ليه؟ ليه ان هي contraindication؟ سوري، انت قلت انها ما ينفعش نعمل ليه؟
ايوه، ما لو if there is no intact posterior tibial arteries يحصل
صح،
no
لكن
healing.
النيوروباثي
ما هو انا بتكلم انه هيبقى البيرن سيرفيس بقى، يعني هيحصل ulceration، ويعني مش هيبقى فيه
الاند
protection.
بيريك insensate.
ايوه بالظبط.
This is صح. It's true but it's a relevant sorry a relative contraindication.
relative مش absolute.
Why؟ طيب خلينا remove this. Do you cut the Achilles tendon؟
No.
How come؟
Because it will go into equinus if we take off the Achilles tendon.
No,
Need it for the balancing.
Are you sure؟
Yeah,
no.
it's part of the muscle balancing.
This
So,
is sorry Mr. Muhammad, believe me, I'm sorry. This is examiner is pulling your leg. ما تتطوعش. ما تتطوعش. If you remove the calcaneum, by definition you remove the Achilles tendon. صح؟
مظبوط.
طيب, what will happen to the Achilles tendon?
Retract.
It will retract, صح. Okay? طيب, if it doesn't retract or leave it attached to the soft tissue, what will happen?
بولين يعني بكرن كده يحصل بكرن.
تمام؟ الباكرينج ده, if you have a Symes amputation, somebody tells you reflect the heel pad to the bone. By the way, do you leave the malleoli?
Resect الماليولار.
Resect them how many centimeters above the ground?
هو مش عارف كده انا كويس قوي ان انا عارف ان احنا بنعمل ريسكشن
1 centimeter.
1 centimeter above.
ليه؟ عشان to leave for me 8 centimeter of area I can fit an ankle in it.
Okay.
خلاص؟ ليه؟ When you reflect it, again you do osteomyelitis. You don't do myoplasty only. Because of the pull of the fibrous tissue remnant, which is attached to the soft tissue here of the Achilles tendon, it will pull the heel pad posteriorly or laterally, would end up by having a painful drifted heel pad. Okay? How you describe this? It's an end-bearing Symes prosthesis طويلة. Ugly, لأنها has control over the remnant of the Achilles tendon of the malleoli, still bulgy. So how can we overcome this? You'll see a prosthesis with a window like that. So the patient put his thumb here, here, and then get it out from here till he passes this tight area and then push it back in it and cover it back again. Okay? This is the ideal part, but what is the main problem here? Dog ear. Why? Because the skin was not refashioned. The downside of it, it is very minimal area for us to fit a prosthetic or a decent modern foot and ankle. Okay, what is the indication? Mainly for old people here. Or for children with, اللي هيقول دي هبعت له 5 جنيه. Children with a common condition. We do science for
Arthrosis
of
neurofibromatosis.
Hemimelia, fibular hemimelia.
Why?
And they have like a ball and socket ankle. And
I think, see, I'm pulling your leg.
تعال.
So what is the idea here is we do it for proximal focal femoral deficiency, PFFDs. Okay? دي أنا بناخدها في congenital إن شاء الله لو ادانا ربنا العمر. Is that okay? This is our basic principle, by the way. And what is that? MRI. Look at this. What is that? It's a drift of the heel pad. ليه? A surgeon, he didn't pay attention, didn't leave. He did myoplasty only, and it ended up by posterior draft. Achilles tendon, fibrous tissue is pulling. خلاص? Now, what is that?
Transmetatarsal.
Excellent. Is it good or bad?
Bad.
ليه?
Balancing.
It's good. Yeah. But you said something right. What is balancing here?
Extensor and flexor tendons.
Important to transfer the transfer tip. فاكر ان كان في
what is left behind here?
the tip anterior insertion
الأكيلس tendon is still there.
كويس.
صحيح. العيان في plantar flexion. لو أنت if you don't do Achilles tendon, percutaneous Achilles tendon or Achilles tendon lengthening, it will goes into equinus straight away. Yeah, is it good? Why? Because this is how would you plan for this surgery? How do you make it? The second ray should be the longest, and then 15 angle. And if you measure here, angle up to here is 15 degrees.
هو اللي بيخش في اكوينس يا دكتور اشرف. احنا عندنا بريزيرفد تبقى انتيريور، وعندنا بريزيرفد برونيوس بريفيس، بريزيرفد بوستيريور انسرشن. all the
فين البرونيوس longus is inserted?
in the base of the first method.
There's a fifth.
بشاور لك. لا وهنا هي بتخش كده longus، مش كده. طول الاناتومي بعافيه شويه ولا؟
base of first metatarsal.
هو البيز اوف فيرست ولا ايه؟
لا، ايوه البيز اوف فيرست ميتاتارسل. بس ايه المشكله هنا؟ لو العيان ده transmetatarsal specifically, if he's not well balanced, he goes into equinus. So you have to make sure you put him in a shoes where it contain his ankle, and في الشوز دي في sole plate و toe filler. Okay, or you put him in this silicone device, but this is not good enough to control the remnant of the toes in the toe of part of the gait. Had end up by patient goes move ankle out all the time. The tibialis posterior is not well functioning here.
Okay.
هاي نخش على بعضه. So لا هقول لك بقى. Sorry. What is that? هو ده اللي انا اقصده by the way. What is that?
Void amputation.
Well هبلعها بس.
لا دي بس partial
Absolutely partial calcaneectomy.
بتعمل الدايابيتيك بيشنت لما يبقى عندهم
Is it good or bad?
osteoarthritis.
Good or bad?
Sorry, osteomyelitis. Good or bad?
Can you mobilize on this?
لا.
What else?
flat foot deformity.
في partial calcaneectomy. And what is that?
This is
void.
One of the variation, perigof or void, you cannot comment on this, but this is you fuse the part of the calcaneum to the end of the tibia, but it end up by having a longer, actually it will be long, مش هنقدر نفت anything underneath, صح؟ And it's very sharp to mobilize on. We don't like perigof or void, even if it is an end bearing, but we don't like it from the functional point of view. And what is this now? What you call this is very...
Chopard.
Absolutely. Chopard. So Chopard, what will happen here? What is left?
Talus and the calcaneus.
ده هيخش في plantar flexion على طول.
And what will happen here? In a diabetic person?
Pressure sore.
Straight. Can he walk after that?
No.
You made it longer, you made it with bearing. By the way, when they describe the signs, they said it is good for a patient to walk few steps on the calcaneal pad without using a prosthesis. يعني عين كبير في السن عايز يخش الحمام يقدر يمشي على الباد دي وبيحصل، بس بيزك عليها شويه لانها شورت. تمام؟ فالايم بتاع هنا يقول لك خلاص خلينا نعمل له دي ويمشي عليها شويه كده. يمشي عليها شويه كده يجي له بريشر ألسر. طب ما تشيل ليه؟ يا اما تعمل حاجه ثانيه. Did you hear about Professor Boker?
No.
He's يعني retired now. He told us in one lecture, if you cannot do a proper muscle balancing, do a science. Why? What do you need to take here to muscle balance? Because this is a case of exam, by the way. I've done this as a case.
I need the tip ant عشان تبالانس.
حطها فين؟
ما فيش بقى.
مش عاوز اقول كلام مش كويس.
ممكن you may put it in the talus neck.
والبيرونيوس longus.
Peroneus longus will be
تيلس، واحدة في النك واحدة في البطن. طيب تعمل ايه في الاكيلس ده؟
lengthening.
بس كده خلاص، يبقى انت نجحت في خلاص؟ طيب. What is that?
Is this frank?
Absolutely. Well done. I have the same problems. Look at it. It looks good on the X-ray, but when it looks at in reality, it is an awful one.
Ugly.
Okay? Have the same issues يعني. طيب. What is that?
Partial metatarsal.
Ray amputation. Ray amputation.
طيب. ده العيان بتاعي. ده العيان اللي كان عنده جريت ستوك باي ذا واي. فالناحية التانية بتاعته two clawing of foot, pressure area from here, there, and leaving Dallas. How many operations did he have?
Many.
About 6. He could have died in one of them. These are non-functional. If you lose the big hallus, here, you lose the medial arch. Yeah? صح? Once you lose the medial arch, and possibly here part of the lateral arch, you lost the whole foot. So you might as well do a partial foot. طيب. So now آخر summary transtibial عملنا comment ال PTB total contact, types of interface, socks, cotton or liner, type of suspension, sleeve or belt, socket comfort score. Socket comfort score means how comfortable are you in the socket between 1 to 10. Not the walking distance, not the speed, not anything. أنت comfortable ازاي within the socket. Okay? 10 أحسن حاجة، 0 أوحش حاجة. Mobility with or without walking aid. نفس الحكاية بالنسبة للترانسفيمورال type of socket, ischial bearing, ischial containing or end bearing اللي هو بتاع through knee. إيه هو الانترفيس؟ إيه هو type of knee؟ type of feet زي ما احنا اتفقنا قبل كده. اوكي؟
كل حاجة.
نعم؟
السلايد دي فيها كل البروسيسز كله.
ما هو ده اللي انت هتقوله في الامتحان، ده اللي ابتدينا بيه الاول.
ده اللي مطلوب صح.
طيب اورثوتيك ديفايس انا عملتها بسرعه، الدكتور محمد قال لي اعملها بسرعه. اورثوتكس السيميلر يعني هوريكم كم مثل يعني. اورثوتيك ديفايس to align or correct a deformity. It is custom made. Simple as that. الفانكشن support the joint. If you have a knee طبعا بيبقى hinge او not hinge والانكل وكده. Prevent injuries. واخد بالك؟ سلايدز موجود جنبك. reduce the pain especially في البلانتر فاشيايتس، في الشوبار، في التيبيالس posterior insufficiencies، وcorrect spinal deformity spinal brace. طب evaluation هيجي لك حاجه كاربون فايبر كده شكلها جميل، لازم تشيك اذا كان good anatomical fit ولا لا، وجود biomechanical function. ممكن it looks very good لكن biomechanically مش supporting the leg. تمام؟ easy to put on and off و comfortable to wear. طيب في اللور limb mainly، الupper limb برضو صعب قوي يجيب لك حاجة يعني. prevent or correct deformity or reduce the pain during weight bearing or actually في swing pace as well. وimprove the base of support والlateral support في الhinge process. Consider ايه بقى؟ if there is any يعني if you have an insensate ulcerative painful skin problem we put it on a carbon fiber immediately, it's not going to be a great idea. Contralateral biomechanics, we don't walk on a single limb, we walk on the other limb. فلو في discrepancy في اللينس، في الهايت، في الجريدينت بتاع الايكواينس، في الجريدينت بتاع الفوت itself, we're going to have a problem with the spine and the pelvis. Lack of sensation, again, is relative, not contraindication. Type medical intervention. Does this patient need only orthotic, or he can manage with spasticity medication or Botox? Yeah. Surgical intervention. Does he need lengthening of the hamstring? Does he need Achilles tendon lengthening? Does he need adductor tenotomies, and so on? Assessment. بنأسس الفوت and ankle, و I've seen your excellent presentation على الفوت and ankle biomechanics. Imaging very important, as we have seen. Foot pressure analysis with gait analysis, absolutely important. Don't take it lightly. We have seen that. It looks good on the X-ray, but bad in the functional part. Foot. Now, what is this type of gait? Let's say this one. This is a very common, you have seen it all the time.
The crouch gait.
Spastic gait?
Why? Do you need orthotic here?
No, spasticity is the issue.
Sorry?
It's orthotics. It's mainly due to spasticity. So orthotics might
So
not help it.
how can we deal with that?
Either medical or surgical in terms of Botox injection and muscle
Where do you inject the
relaxant.
Botox here?
Sorry?
Where do you inject the Botox?
So it's multi-level, will be hamstring and calf, gastroc and soleus.
On which leg?
I believe the left seems to be more spastic than the right.
What you're going to achieve after that?
So it might get slight better walking, but it's complex problem. So if I'm thinking orthotics, it might just be accommodative, not corrective, accommodative type of orthotics, but not corrective, because the with the spasticity, there'll be no correction with orthotics.
What about this foot? So if I'm pulling your leg, So you are digging, you're putting yourself in deep trouble. Okay, go ahead. What is this foot?
That's
When you describe
probably.
it, think about the patient as a function, not as a foot.
So,
first of all,
this foot is equinus. You want it to be plantigrade foot to be able to walk. Or
what about the knee?
to fit orthosis, you need it to be plantigrade to be showable or to be like pressable. So that's why we give the Botox to help with the orthotics.
How many milligrams of Botox you're gonna give? How many units?
No, I don't know.
Yeah. So the idea here is just to say, I see a patient with spasticity, flexed knee, plantar, not plantigrade. What do you call it about this foot? The left foot.
The one in the middle.
في middle foot هنا.
دي في الصورة اللي في الليفت.
أنا حاطط على الكرسر. Right.
Base plano valgus. And
is the foot pronated?
Pronated, yeah.
Or supinated.
مش شايفينها قوي بس هي pronated.
طيب يبقى انت قول لسه هيكزامن البيشنت واشوف اذا كان pronated ولا supinated، صح؟ طيب عنده حاجه في البلفس؟ For the idea here is just to tell the examiner I need to fully assess the patient and to see what is the aim here. Are we asking him to, is he walker or not walker? Yeah? Is he gonna walk or not? Is it gonna be medical or surgical? Are we gonna correct the foot deformity or not? So you describe and you tell the patient, tell the examiner that is a complex case without giving a specific type of surgery. Can he use an orthotic? Possibly, yes, after releasing his spasticity, either medically or surgically. But we prefer medically, as you said. You said the right thing. Like Botox, we usually give 400 units per time, repeated every 3 months, and it has to be followed by stretching and maintaining the outcome with an orthotic device. Custom-made orthotic device. Why? Because there is no off-shelf orthotic which can usually accommodate this type of spasticity. Can he walk after that? Most likely crouching again, but it will be less painful.
الجرافو orthosis ممكن to improve his condition?
A little bit. And it has to be followed up all the time with stretches, possibly surgery. But if you do Achilles tendon only, because some orthopedic surgeon will do Achilles tendon only here, and then you weaken this muscle, end up by patient sitting in the wheelchair. Spasticity can be sometimes beneficial. Don't forget that the patient has hip spasticity as well. Do we need a global spasticity agent? Might be, either oral or anything like intrathecal baclofen. There are some other issues here. So there is no one single answer here. Do you know what I mean? It's a functional unit, a functional patient. Okay? Look at the patient's foot in here, next one. What is the main problem here?
Sorry, which picture?
اللي حاطط عليها كيرسر ده.
في valgus deformity in the knee.
ايوه.
Equinus deformity in the ankle.
Foot and ankle. Pronation supination, which joint control the pronation supination?
Subtalar.
صح. سلام. Or start in the subtalar joint. What else?
Hip and knee flexion.
Absolutely. So do you tackle this with an orthotic device?
No.
So here you go. When you answer is as I need to examine him, the hips and knee, and what is the patient functionality, what is he aiming to do in the future, how can I tackle this joint?
Correctability of the deformity as well.
How can I tackle it? And what is the functional outcome needed for the patient? You said valgus, fair enough. What about the hip? What about here? What about this knee? What about this hip? So don't underestimate a gait analysis. See the last picture? What is the problem here?
Recurvatum.
Absolutely. Can it be corrected? Yes. Will it affect the other joint? Maybe. So gait analysis is indicated. There is no single answer like, yes, we have to have orthotic for this. Same like here, cerebral palsy as well. Adductors, yeah, planovalgus, crouching, okay? Foot pressure scan is very important, and gait analysis as well. So what sort of orthotic? It depends on, there are so many orthotics. The aim here is to correct the deformity, provide a painless gait, biomechanics of the diseased limb and the contralateral limb. Okay? What do we have here? You remember the Chopard? Chopard, we cannot fit it with one of them, a foot plate with a toe filler. Why? Because it's an equinus, so you have to control the hind foot and put either an anterior or posterior AFO, like this one, to control the equinus created, and then fit him with an orthotic foot. Okay? So for orthotic, it's not a sole decision. طبعا, unless it's coming from you, we have to bow and say, yes, you're right. MDT, orthopedic, vascular, TVN, rehab, people you know. With all due respect to our rehab team, physio, OT, and whoever, respect their views, but don't presume that they know better than you. They don't. You'll be surprised. And again, we are treating human beings, not feet or legs. Think about the cognitive ability of the patient, bone status, muscle status. And don't forget that we have another side of the body, the contralateral, and we have social issues. Yani, don't tell me in Egypt that we have a transfemoral living on the 5th floor and he's 90 years old and you fit him with a prosthesis for the sake of money and he won't be able to use it. Yeah? So it's an integral to the team to have orthotics and podiatrists, not only as an outpatient, but as an acute outpatient, inpatient. Thank you very much, guys. This is my email. If you need anything, just email me.
Thank you so much.
No problems at all. I hope it made sense today.
Yes, too much.
Thank you.